pancreatitis. Pancreatitis is inflammation of the pancreas. Pancreas produces digestive enzymes and number of hormones. There are two main types of pancreatitis, acute and chronic. Acute pancreatitis, it is a sudden inflammation of pancreas. It can be single event or recurrent and sometimes lead to chronic pancreatitis. What about causes of acute pancreatitis? It includes gallstones, which is impacted in the common bile duct beyond point where pancreatic duct bind, especially in the ampulla vata. Also, heavy alcohol use, systemic diseases, trauma as post-endoscopic retrograde cholangiopancreatography or abdominal trauma, infection, especially MUM, viral hepatitis, cytomegalovirus, mycoplasma, and ascaris. Radiotherapy, autoimmune pancreatitis, idiopathic in 25%, drug, and the main drug that causes acute pancreatitis including diuretics such as the thiazide and furosemide, Cliptin as valdagliptin and sitagliptin, tetracycline, sulfonamide as antibiotic, azathioprine and mercapurine and steroid. All these drugs can involve in pancreatitis. What about symptoms? The patient usually presented with severe epigastric pain and especially in the right upper abdomen, radiated to the back in 50% of cases, and usually aggravated by eating and drinking and relieving by fasting and sitting upward and bending forward. Nausea, vomiting, loss of appetite, fever, chills, sometimes hemodynamic instability, especially tachycardia and hypotension, peritonitis, hiccup. There is uncommon sign can present a patient with acute pancreatitis such as Gray Turner sign, which is a hemorrhagic discoloration of a flank, and Gullin sign, which is hemorrhagic discoloration of umbilicus, sometimes presentation as a pleural effusion. What about the complication of acute pancreatitis? We have two types, local and systemic. Local, especially in the what we call pancreatic pseudocyst. This is the most common complication, occur in about 25% of all cases and typically occur after 4 to 6 weeks of acute pancreatitis. Pancreatic abscess, thrombosis of the splenic vein, mesenteric and portal vein, hemorrhagic from erosion into the splenic artery, obstruction in common bile duct and duodenum lead to intestinal obstruction, and chronic pancreatitis. What about the systemic complications? Sometimes acute pancreatitis lead to respiratory problem, especially acute respiratory distress syndrome, which is severe type of respiratory failure, multi-organ dysfunction syndrome, DIC, which is mean disseminated intravascular coagulation, leukocytosis, anemia as a hematological complication. What about the metabolic? The patient presented with hypocalcemia and hyperglycemia. Circulatory, such as arrhythmia, shock, myocardial infarction, pericardial effusion. Sometimes complication lead to the diabetes mellitus, especially type 1 insulin-dependent diabetes mellitus. And this is mainly due to distraction of beta subunit of pancreas. Also malabsorption and malnutrition as a systemic complication for pancreatic disease. What about the diagnosis? Diagnosis usually clinically, but also we have the blood test can lead to beneficial or of value in patients with acute pancreatitis. Complete blood count for leukocytosis and anemia, renal function test, liver function test, calcium because it will be hypocalcemia as I said before, serum amylase and lipase, this is enzyme from pancreas, arterial blood gas analysis, especially in patients with hypoxemia or acute respiratory distress syndrome. Also, there is a test called trypsin selective test. This is some points about serum amylase and lipase. Elevated serum amylase and lipase with severe abdominal pain often trigger the initial diagnosis of acute pancreatitis. Serum lipase rises 4 to 8 hours from the onset of acute pancreatitis and lead to normalization within 14 days. Serum amylase may be normal in 10%. And if the lipase is 2.5 to 3 times more than amylase, this is indication pancreatitis due to alcohol. Lipase is more sensitive and more specific than amylase, as I've said before, because 10% with acute pancreatitis there is a normal serum amylase. In addition, maybe appear as a false positive. That means it will be presented in parotitis and some carcinoma. What about the imaging? Triple phase abdominal CT and abdominal ultrasounds are together gold standard for evaluation of acute pancreatitis. MRI in case of allergy to the contrast with CT, or in case of the fluid collection and pancreatic necrosis. MRCP, that means magnetic resonance cholangiopancreatography for searching for etiology. ERCP, which means endoscopic retrograde cholangiopancreatography, this is for as a therapeutic and diagnostic. And abdominal X-ray, this is the last test, can be used as imaging because it is not valuable in acute pancreatitis, especially or accepted in case of complication, maybe of value. This is MRCP, picture showing MRCP, magnetic resonance for cholangiopancreatography. And this is therapeutic ERCP by endoscopy. What about treatment? We should fluid replacement 5 to 10 mol per kg per hour of isotonic crystalloid solution, especially normal saline, Ringer lactate, to all patients with acute pancreatitis, except in patients with heart failure and severe renal failure. Pain control or painkiller, for example, opiate, because the patient presentation is very severe abdominal pain. Bowel rest, null by mouth, low fat diet. Oxygen, antibiotic, and ERCP as a therapeutic for gallstone, especially when it is in common bile duct. And surgery. What about the chronic pancreatitis? It is a long-standing inflammation of pancreas. It is disease process characterized by irreversible damage. Causes mainly alcohol, autoimmune, intraductal obstruction, idiopathic, tumor, ischemia, calcific stones, and hereditary as cystic fibrosis. What about the signs and symptoms? Also presentation same to the acute pancreatitis with upper abdominal pain, which is increasing by eating, drinking, and lessening by fasting and sitting and leaning forward. Nausea, vomiting. But the difference here is steatorrhea because it takes a long time. Steatorrhea means frequent oily, foul-smelling bowel movement. This is due to damage to the pancreas, which reduce pancreatic enzyme that aid digestion, which can result in malnutrition and malabsorption, especially for fat. Weight loss, also this is difference as a sign or symptoms between acute and chronic because it takes a long period, even if the patient is normal appetite. He had weight loss. Diabetes type 1, because as I said before, there is a destruction of beta subunits of pancreas leading to the diabetes mellitus. Diagnosis. Serum amylase and lipase may be moderately elevated in patients with chronic pancreatitis. Secretin stimulation test is regarded as a best test for diagnosed chronic pancreatitis. This test, also called pancreatic function test, for detection pancreas function, and mainly used in patients with pancreatic insufficiency, in patients with chronic pancreatitis, in patients with pancreatic carcinoma, in patients with cystic fibrosis. Secretin is usually hormone produced by upper small intestine, especially from the duodenum, when the partially digested food comes from the stomach. lead to secretion of the fluid contain digested enzyme from the pancreas. So here for test we do endoscopy by from nose reach to the duodenum by tube inserted from nose to the duodenum, and injected the secretin hormone IV, and see the function of the pancreas if it is secreted fluid that contains digested enzyme or not. So we can see the function of the pancreas. Normally excreted pancreatic fluid with digested enzyme. If not, that means there is a pancreatic insufficiency. Also by use serum trypsinogen, CT abdomen, and abdominal ultrasound as used in acute pancreatitis. What about the treatment? Treatment usually directed to treat underlying cause. Also same as we used before in acute pancreatitis, we can use in chronic pancreatitis by medication measure, include painkiller, malabsorption treatment, insulin dependent diabetes mellitus treated with insulin for long time, alcohol cessation, and dietary modification with low fat diet. Also we should replace for enzyme because, as I said before, there is a pancreatic insufficiency here, so we should replace for this enzyme, especially in case of malabsorption or steatorrhea, which is mean fatty diarrhea. Surgery at least. Surgery here can use in pancreatic pseudocyst, or in case of pancreatic fistula, or in case of intestinal obstruction as a complication of chronic or acute pancreatitis. Thank you for listening.